consultant neurosurgeon and neurointerventional surgeon from Apollo Hospitals, Chennai. So today, what I thought is I will share with you about minimally invasive neurosurgery. So when we speak about minimally invasive neurosurgery, two important subspecialties come in that. One is endoscopic neurosurgery and the other one is endovascular neurosurgery. These may be very difficult names for you to crack, but I will explain about that. 1950s, we started neurosurgery in India. Those days, we started doing surgeries with bare eye. There is nothing else. We just look at the brain and we start operating the brain tumors and whatever the vascular lesions, whatever is there inside the brain, and come out. This is what the neurosurgery in 1950s we were practicing. In 1980s, we started getting microscopes into the field. So operate under the microscope. So better visibility, better light source in the microscope enable us to understand the brain tumor or any other lesion inside the brain much more clearly, and we started operating with less morbidity and less mortality. So less damage to the brain and less death rates. End of 1980s, we started getting CT scans, MRI scans and all that into the field. So what happened is that we had better delineation of the brain as well as the brain tumors and other structures like blood vessels supplying the brain and all that. We can find out even before operating. We do an MRI, we do an MRI angiogram, we do a CT angiogram. We learn everything before we go inside and operate on the brain tumors. So this made us to make the surgeries less and less invasive. So in microscopic surgery, we had to put in a big incision over the scalp. Then we open the skull and then we go inside, retract the brain, and then we reach the tumor where it is. And then we start removing the tumor. This is microneurosurgery looking under the microscope. Now in the last 10-15 years, slowly we are becoming more and more minimally invasive. So what we do is, many of these lesions inside the brain, like brain tumors or any bulging inside the blood vessel which produce the hemorrhage, bleeding inside the brain, we call it aneurysms. And AV malformations, which are congenital malformations. From birth onwards, there are abnormal arteries and veins inside the brain, which produce the bleeding inside the brain, in babies as well as in grown-up individuals. These we started operating without opening the skull. How do we do that? This is done through two methods. One is, as I told you, the endoscopic surgery. The other one is the endovascular surgery. In endoscopic surgery, we put small hole, 1 or 2 centimeter size. Through that we pass in a tube we call the endoscope, which have fiber optic filaments, which allow us to see through the scope, and it will be connected to a monitor through which we can see and operate inside the brain. So minimally invasive means we are going through by opening very minimal inside this on the skull and reach inside, deep inside tumors by using the endoscope and remove the tumor and come out. The other branch is endovascular surgery. When the moment we say endovascular means we are inside the blood vessel. There are certain lesions inside the brain which produces bleeding inside the brain. These lesions are situated in the arteries supplying the brain. Either it could be an aneurysm or it could be an arteriovenous malformation. When we say aneurysm, what is an aneurysm? It is a balloon-like swelling of the artery. The artery is the tube which takes the blood from the heart towards the brain, the oxygenated blood. These tubes which get balloon-like swelling and that ruptures, which produces the hemorrhage, patient being unconscious and serious. When they take to the hospital, they do an angiogram and find out that there is an aneurysm or a balloon-like swelling which has ruptured. Now we have to treat this. Earlier, we used to treat this by opening the skull and go inside and put a clip in the neck of that aneurysm or the balloon-like swelling so that it doesn't bleed again. Nowadays, we do it through endovascular route. Endovascular means we pass it through the groin. There is an artery which supplies the leg. We call it femoral artery. We put in a needle through that, and through the needle we pass small wires, and over the wire we pass in a tube. Through this tube, multiple small tubes can be passed. These tubes can be taken into the brain, find out where that bulge exactly is, pack it with platinum coils, and come out. This can be done by using stent and support it and pack with more coils, or we can use balloons inside and pack it with more coils. There are various methodologies are there, but the basic funda is that we have to pass in a needle through the femoral artery. Through the needle we pass in the wires and catheters, Through the wire, we pass the coils and pack it so that it doesn't bleed again. This is called endovascular neurosurgery of treating aneurysms. Like that, as I told you, arteriovenous malformation. That may be difficult for you to understand. I will tell you simple what it is, in simple language. Artery takes oxygenated blood from the heart to the brain. The blood has to come back, that is through vein. Usually it goes through capillaries, give the oxygen, take the carbon dioxide, come back through veins. From birth onwards, if there is an abnormal connection between the artery and vein, then when there is an abnormal connection, a bundle of abnormal blood vessels, it is called arteriovenous malformation. Usually we know the blood pressure when we check in the arm, 120/80, you might have heard. Everyone, you will ask the nurse, how much is my blood pressure? Sister will say 120/80. So what does it mean? The arterial blood pressure it is. The pressure inside the artery is 120/80. How much is the normal pressure inside the vein? It is 0 to 5. A vein cannot take such big pressure because vein is made of very thin walls. It will break. Artery can hold 120 pressure, but vein cannot. So when there is an abnormal connection between artery and vein, what happens? This pressure of 120 will go into the vein and it bursts. This is why the bleeding happens in these abnormal blood vessels called arteriovenous malformation. So what happens? Suddenly patient develop a fix or something. Patient is taken to a hospital. They do a CT scan, find that there is a bleed. The doctor will say that this bleed could be due to arteriovenous malformation. Now we have to do an angiogram. They do an angiogram and find out that there is an abnormal connection between artery and vein and need a surgery. This used to get operated by opening the skull, going inside and clipping it and taking out the blood hematoma and the abnormal connection of the artery and vein. Nowadays, by endovascular neurosurgery, we don't do that. We go from the groin, passing these catheters inside, find out exactly that connection where it is, we inject certain chemicals inside and block it. That's it. So the healing is done and the patient can be discharged in 2 to 3 weeks' time. When we are operating big invasive surgeries, patient remains in the hospital for a longer time. Sometimes 15 days, sometimes 20 days to recover from this cut wounds and all that. Chance of infection rate is also there. These things are not there when we are doing endovascular neurosurgery. So nowadays we call it pinhole neurosurgery because through a pinhole we are doing all this. We are not opening the skull here, through a pinhole in the groin we are doing all these procedures. So endovascular surgery and endoscopic neurosurgery has become the least invasive neurosurgeries. We collectively call them the minimally invasive neurosurgery. So I thought that I will share with you this idea of the procedures which we are doing. This had been there for last few years. We have done thousands of these cases with good track record. We can say confidently that we can do this minimally invasive neurosurgery with great good results and minimal hospital stay. Of course, the surgical cost, if we talk about endoscopic neurosurgery, the surgical cost is almost the same. It comes to around 4 to 5 lakh rupees or sometimes 3 to 4 lakh rupees. But when it comes to endovascular neurosurgery, for example, there is an aneurysm, we have to pack it with the platinum coils, we have to use these catheters and all that. These catheters and tubes and all what we use are use and throw. We cannot reuse it. So once we use it, it has to go to the dustbin. These are consumables which add on to the cost. So we should understand when we do endovascular neurosurgery, it is going to become a bit more costly. It may be from 6 lakhs or 5.5 lakhs or so. And when we open up the skull and do the surgery, they have to remain in the hospital for a longer time. 2 costs can add up. One is when you stay in the hospital for a longer time, the cost adds up a bit more. Second is that as he goes home and start working early, he can earn as well. So when they do the endoscopic and the endovascular, they go home early and they can definitely earn a bit better earlier and compensate for the cost which happens due to this minimally invasive neurosurgery. Most of these patients are very happy about this because it is less cut wounds. So naturally, they feel very happy. Some of the tumors in the skull base, we don't have to put any hole there at all. We can go through the nose and reach the place. Especially pituitary tumors. You might have heard the pituitary gland, which is the master of the endocrine orchestra, we call it. Because that is the gland which completely controls all the glands in the human body. We call it the master of human endocrine orchestra. So that gland can have a tumor, we call it pituitary tumor. When we operate this, earlier and all we used to operate through the skull, but nowadays we go through the nose and reach the place and we can remove by endoscopic neurosurgery. So these minimally invasive neurosurgeries is revolutionizing the field of neurosurgery. Brain tumors, as I told you, many of them go for endoscopic neurosurgery. And vascular lesions like aneurysms and arteriovenous malformations, which earlier we used to operate by opening the skull, which is going for now pinhole neurosurgery or endovascular neurosurgery. So this altogether comes minimally invasive neurosurgery. So any doubts, anything you would like to clarify?
But do you think what is the main cause behind it?
Behind the tumors and behind these vascular lesions? See, always understand that when we age, every structure in the body goes through certain changes. We don't look the same after 10 or 15 years. So naturally these degenerative changes take a toll on these blood vessels. That is how the blood vessels get damaged. Some of them are congenital. As I told you, the aneurysms, the bulgings which happens and burst and all that, that happens more often in those patients who have hypertension. For example, blood pressure for longer days. They don't control, they don't take the blood pressure tablets. The pressure inside the tube becomes too much that it can start bulging in the bifurcations. Bifurcations means where it branches out. The branchings are weaker. Whenever a tube branches, that junction will be weaker compared to the rest of the tube. Am I right? The same way, the blood vessels are weaker at the places where they branch. Those are the places where we get these aneurysms. So I would say that some way it is due to the degenerative change due to the aging, some way it is due to that innate weakness at that particular area, and adds on to that is you miss the hypertension tablets. So that again creates pressure on that area, start bulging out. Some of we are seeing aneurysms even in small children. So from birth onwards that area may be weak in some people. So that can.
How to control it or how to minimize this disease?
See, if you ask me how to minimize aneurysms developing, I would say that better after the age of 25, go for a health checkup and find out, especially if you have headache or any other symptoms of an aneurysm, go for an angiogram and find out if it's there, especially if your parents had it, your close relatives had it, go for an angiogram and find out if you have it, and then screen properly, I would say, if you are hypertensive, at least every 3 years.
What is the symptoms? Quite symptoms of the particular.
If there is a hemorrhage, usually the patient will say that I had a headache today morning, which I never experienced in my life. The moment the patient say that I had a headache which I have never experienced in my life, understand that it is a bleed. Usually we know that many patients have migraine. They will say that, oh, I had a headache. I used to get it before also. I had it 3 months back. I had 2 months back. My mother also used to get headache. That is, we have headaches or vascular headache, we call it generalized migraine headaches. We can give some tablets and that's enough. But the moment patients say that, I had a headache today morning, I never had such a headache, it is blasting in my head. He requires evaluation. Consult a neurologist and evaluate whether it is due to any of these problems. Apart from the brain tumor patients, the symptomatology is different. It is not like this. Many patients will have headache. But understand that the headache, if it happens in the early morning, when you get up from the sleep, you have a headache, you have to be suspicious. But even the headache in the afternoon, you are tired, you didn't have your lunch, or you didn't sleep properly in the previous day, it's fine. But if you get a good sleep, and early morning you had headache, you have to be suspicious. Early morning headache is vomiting, more suspicious. And early morning headache, vomiting, and after vomiting, you feel relieved of headache, you have to be even more suspicious. Yes.
What is the precaution? What is to maintain the patient?
See, as I told you, these surgeries don't have big cut holes. We are going through small holes. Either it could be through the nose or it could be through the bone where we have made a 2 centimeter hole through which we are passing the endoscope. When we are going through the nose, we should understand that there is a possibility for the water from the brain to leak. So if there is a water coming through the nose, we should understand that that water could be from the brain. And we need to consult the doctor again back and say that we have got a water coming through the nose. We should not think that it's a running nose. It need not be. So we have to rectify that. Some of the tablets which are given at bed rest usually heal that thing and goes away. If the water leak continues, there is a possibility of meningitis developing. As if you compare with the infection rate, that is what I told. So you have to watch for this water leak if you are operating through the nose. If you are operating from here, the less the morbidity is, less chance for seizure to happen compared to the other open surgeries. Less chance for infection to happen compared to other surgeries, but you should be watchful again of the incision and that they are getting any infection, whether they are getting fits, there have to be precautions about. But other than that, this morbidity due to this per se the surgery is much lesser. But then the morbidity of a tumor surgery depends on where the tumor exactly is sitting in the brain. If, for example, it is in a very important area, the patient can have weakness, but that's not due to the type of the surgery, that's because of the tumor, where it was sitting. And another reason is that if it is cancerous or non-cancerous, if there is a cancerous, those tumors can come back again. It's not because of the type of the surgery, it's because of the type of the tumor. So we cannot attribute to that. But if, for example, if the patient had an endovascular surgery for coiling of the aneurysm, we should follow it up because they can have recurrence of the problem. So after 3 months, you should visit back the doctor, and usually we take an X-ray to find out whether the coils can be seen in the X-ray. So we have to see that the coils are moved or not, whether it is in the same position or not, the shape is maintained or not. So follow-up is very important in this case.